Good evening, ladies and gentlemen. I'm going to give you the definite debate between the carotid stenting and carotid endarterectomy. So I'm going to straight away address the elephant in the room and give you the most important message early on. Prior to July 11, 2023, my task would have been more difficult, but today my job has been made easier by the Center for Medicare and Medicaid as they published a landmark decision memo approving payment for carotid artery angioplasty and stenting after reviewing the weight of all evidence. On July 11, 2023, the CMS proposed that the coverage for carotid angioplasty and stenting is reasonable and necessary for Medicare beneficiaries under the following conditions. Number one, patients with symptomatic carotid artery stenosis greater than or equal to 50%, and patients with non-symptomatic carotid artery stenosis greater than or equal to 70%. For both 1 and 2 above, if either CT angiography or MR angiography is used as a first-line imaging, no second-line imaging is required. As in, ultrasound is not required for centers like ours with CT angiography-driven evaluation of stroke and TIA. Ultrasound is not needed for evaluation of carotid stenosis. The CMS has expanded coverage to standard surgical risk individuals by removing the limitation of coverage to only high surgical risk individuals. The following are the key clinical questions that the CMS has addressed in their memorandum after reviewing the weight of all evidence. Does carotid stenting improve health outcomes similar to carotid endarterectomy in symptomatic patients with carotid stenosis? Their answer is yes, and carotid angioplasty and stenting does so for symptomatic patients with standard as well as high surgical risk. The evidence is stronger for patients with carotid stenosis greater than or equal to 70%. However, there is evidence supporting carotid stenting for stenosis of greater than or equal to 50% as well. Does carotid stenting improve health outcomes similarly to carotid endarterectomy in non-symptomatic patients with carotid stenosis? And their answer is yes here as well, and again for patients with standard as well as high surgical risk. The ACST2 trial supports coverage of non-symptomatic patients with standard risk and carotid artery stenosis greater than or equal to 70%. Having said that, let's do the comparison between the clinical evidence regarding carotid endarterectomy and carotid stenting. What is the weight of the evidence? The clinical evidence supports equipoise between carotid endarterectomy and carotid stenting. I strongly believe that the clinical evidence does support equipoise between CEA and CAS. The argument that there is a lack of evidence supporting carotid stenting as a proven and reasonable alternative to carotid endarterectomy is patently wrong, as it is tiresome. Frankly, that a group of physicians championing TCAR, which lacks a single randomized patient, and carotid endarterectomy, which has developed no comparative data on high surgical risk populations, would contend that the extent and voluminous clinical evidence on carotid angioplasty and stenting in the modern era, that is using embolic protection devices, appropriate patient selection is somehow inadequate, makes it even more specious and smacks of protectionism. The CMS has based this proposed decision memo on repeated level 1 evidence from landmark randomized control trials reporting results in greater than 8,000 patients in multiple trials over the past decade. The major trials are the CREST, ACT 1, SPACE 2, ACST 2, all with consistent results demonstrating parity with endarterectomy, and no randomized trial in this era that did not show non-inferiority. It is also inappropriate and opportunistic to focus on the results of older studies, as in EVA 3S, ICSS, SPACE, and any meta-analysis from the carotid trial is collaborative, or others that includes these studies, which are widely discredited as flawed in both design and conduct. The 4 major randomized trials, the CREST, the ACT1, the SPACE2, ACST2, were all powered to specifically address a composite endpoint, which was chosen because estimates of the rates of the individual components as in death, stroke, and myocardial infarction, were so low, and the expected difference between CAS and CEA outcomes was so small that only could a combined endpoint result in a realistic trial size. As previously described, all of these large, well-conducted trials showed no difference in the composite endpoint between CAS and CEA. While there were all landmark trials vetted by the reviewers and editors of such venerable publications, such as the New England Journal of Medicine, CREST and ACT1, and the Lancet ACST2, none was designed nor adequately powered to do a subset analysis of the individual components of the composite endpoints. Any attempt to do so violates the statistical premise on which these trials were designed. The key question that often comes up is the effect of minor stroke in TIA versus the effect of myocardial infarction on mortality and the quality of life. So I'm going to address this key question in the very beginning. In the CREST, peri-procedural strokes translated into a significant impact on patients' quality of life based on SF-36 scores, and the impact was found to be much worse than that of peri-procedural myocardial infarction. On the basis of this quality of life analysis among survivors at 1 year, the investigators concluded that stroke had a greater adverse effect on a broader range of health domains than myocardial infarction, and that myocardial infarction in the post-procedural setting is perhaps less of an adverse event than peri-procedural stroke. Nevertheless, this view is controversial and frequently challenged because several studies have shown an association between myocardial infarction and biomarkers for myocardial injury and future mortality in a variety of vascular and non-vascular procedures. Objections that CAS causes more overall stroke than CEA misses the fact that these are numerically very small differences driven by minor stroke, that major stroke and death rates are not different between the therapies, and that minor strokes that occur in both groups are usually resolved without any deficits within 30 days. The balanced observation is that in the CREST trial, myocardial infarction rates were twice as high in the carotid endarterectomy cohort as compared to the carotid angioplasty cohort, and that myocardial infarction was associated with a profound increase in long-term mortality out to 4 years. So why does it matter, myocardial infarction after carotid stenting and endarterectomy? It's because a clinical or subclinical myocardial infarction predicts mortality after carotid intervention, and it should be included in the primary endpoint composite of carotid trials. And myocardial infarction resulted in higher overall mortality versus minor stroke and TIA, which did not. So take your pick. Would you rather want a minor non-disabling stroke or a myocardial infarction with a resultant increased mortality? Postoperative myocardial infarction is an independent predictor of increased long-term mortality among patients who have undergone vascular surgery. Further, postoperative myocardial infarction may have greater effect on mortality after carotid endarterectomy than postoperative stroke. The most recent carotid stent data from the CREST-2 registry, which enrolled a substantial percentage of high-risk patients, data that are well vetted and adjudicated, demonstrated a 30-day stroke rate of 1.4% in non-symptomatic patients and 2.8% in symptomatic patients. These remarkable results from a wide variety of operators in predominantly high-risk and fairly sick patients that did not qualify for a CREST-2 randomization demonstrates that the carotid angioplasty and stenting is performed extremely safely and effectively in the contemporary era. Objections to carotid angioplasty with reference to non-randomized observational data, including claims data that are unvalidated in the face of much more robust data from randomized controlled trials, fails to acknowledge the value of level 1 evidence supporting carotid artery angioplasty and stenting. I'll spend 1 minute on a TCAR procedure. TCAR is a procedure that was studied in Europe, has not been approved in Europe so far. The procedure has been mushrooming all over United States. Instead, there has been a huge PR push by the vascular surgery community in favor of TCAR in the absence of a level 1 evidence. No randomized controlled clinical trial, and the only data are self-reported single-center retrospective case series. In a sense, TCAR is simply carotid stenting via direct carotid puncture. except that it is twice as expensive as transfemoral carotid stenting. Comments regarding TCAR as a preferred alternative to carotid angioplasty and stenting are prima facie invalid, as this technology has never been randomly compared in an adequately powered long-term trial to either carotid stenting or carotid endarterectomy. Relying on real-world evidence to benchmark carotid stenting versus either TCAR or CEA is flawed, as the requirements to perform carotid artery angioplasty and stenting has created a high-risk, non-surgical cohort of patients that prohibits comparison to patients who would qualify for other treatment strategies. Treatment selections and outcome or treatment biases in these comparisons are insurmountable. In the TCAR Roadster 2 registry of 692 patients, the 30-day stroke rate in symptomatic patients was 4.4%. I'll spend 1 minute on radial approach carotid angioplasty and stenting. When we do the radial approach carotid stenting, we can often bypass the aortic arch completely, especially when the right common carotid artery arises directly or the left common carotid artery has a bovine origin. The tools and techniques for carotid stenting has also improved and continues to evolve over time, with inflatable balloon guide catheters as a proximal flow control system to prevent distal embolization, in addition to the distal emboli protection devices and improved double-layered covered stent to reduce the risk of distal emboli. So in summary, there is clinical equipoise between carotid artery angioplasty and stenting and carotid endarterectomy. The numerically higher rate of minor non-disabling strokes in carotid artery angioplasty and stenting should not deter us from performing the procedure. On the contrary, the higher prevalence of myocardial infarction with resultant increase in long-term mortality in patients undergoing carotid endarterectomy should be the reason to prefer carotid artery angioplasty and stenting over carotid endarterectomy. And TCAR is a procedure with no level 1 evidence and is twice as expensive as transfemoral carotid angioplasty and stenting. And finally, transradial carotid artery angioplasty and stenting with the current generation of dual-layer stents, proximal balloon guide catheters, and distal emboli protection devices minimizes the risk compared with transfemoral access, minimizes arch manipulation with resulted decreased risk of periprocedural ischemic stroke. I'm going to stop here and see if you have any questions.